Good evening and welcome to tonight's webinar, Managing Cardiometabolic Health for People with People on Psychotropic Medications, Challenges and Evidence-Based Solutions. I'd like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues joining us tonight. Additionally, I'd like to acknowledge all people with lived experience of mental health struggles. I recognise their vital contribution and value their courage to share this unique perspective. Apologies. So please note that tonight's webinar will be recorded and will be available on CESPN's YouTube channel within the next couple of days. We'd like tonight's webinar to be interactive, so please submit your comments and feedback via the chat box, and any questions you have, please separately submit them via the Q&A box, as this will make it easier to manage and make sure we don't miss any questions. You can access the chat box and Q&A function by hovering over the toolbar at the bottom of your screen. An evaluation survey will pop up on your screen at the end of the webinar, and a survey will also be sent to you via email. We're keen to begin delivering more CPD events on mental health topics, so your feedback and suggestions is greatly appreciated on this. I'd just like to let you know that tonight's webinar has been approved for 1.5 hours of educational activity of CPD points. If you attend the webinar tonight, that will automatically be applied to your account. There is an additional 1 hour of reviewing performance CPD points available as well. And information on how to complete this will be in the post-event email. And I'd like to let you know about a few of CESPN's mental health services. So we have a new mental health service directory, as well as a few free mental health supports, including telehealth psychiatry service and a psychosocial and psychological support service for older people living in residential aged care facilities in the CESPN region. And before I move on, just to let you know that these slides will be shared with the post-event email. So if you would like any further information, you should be able to get it there. And then I would like to let you know about SANE's free guided service, which is individually tailored mental health support for people over the age of 18 with complex mental health issues. SANE offers a range of mental health supports and depending on the level of need of the individual. And SANE are keen to work with GPs and other health professionals. So please reach out to Susie on the email on the screen if you are interested or if you'd like any further information. And some further slides and information will be included in the post-event email as well. So that is all from me. I would like to introduce our speakers for tonight. We have Dr. Andrew Watkins and Catherine O'Donnell. Dr. Watkins is Director of Programs and Innovation at Mindgardens Neuroscience Network. He's a nurse practitioner and has a PhD exploring physical healthcare solutions for people with severe mental illness. He co-developed and was the clinical lead for the Keeping the Body in Mind programme across the Southeastern Sydney LHD. And he's a long-standing interest in the physical health of people with severe mental illness. And our co-presenter for tonight is Catherine O'Donnell, who is the Director of Lived Experience Engagement with Mindgardens Neuroscience Network. And she's responsible for ensuring the integration of lived experience perspectives and co-design in Mindgardens research and educational programs, and brings her own lived experience of mental health challenges to the role. Catherine holds a degree in adult education from UTS and also has qualifications in counselling. She's worked in a range of mental health and physical health care roles over the past 10 years, including peer support worker, peer health coach with the Keeping Body in Mind clinical team and mental health program officer at Central and Eastern Sydney PHN. Thanks everyone. I'll pass it over to Catherine and Andrew now.
Thanks so much, Gloria. Everyone would probably engage there thinking, oh, what a lovely voice to listen to. And then it transfers over to me and it's like, oh, sorry, guys, lucked out. I probably should give the slides to Gloria to present and it'd sound much, much better. But thank you to all of you. I know that everyone's muted out there, but as Gloria pointed out, please do use the chat and the Q&A boxes to interact during this session. And Gloria will be monitoring those and direct us to any comments that might come up. So I did want to thank all of you for taking time out of your evenings. I know that personal time is very valuable and appreciate that you have chosen to spend that with us. Now, today's presentation has been pointed out is all around cardiometabolic health for people that experience a severe mental illness, a topic that Kat and I have been interested in and working in for a very long time. And what we want to get the message across, you'll see at the top there, is that we don't just want to screen for cardiometabolic problems, we want to actually intervene. And this is part of the story of Keeping the Body in Mind Gardens and how that has evolved. But also, most importantly, I'm going to introduce you to a suite of physical health resources that can be utilised as professionals to help guide your practice with this population to manage cardiometabolic health, and also the resources there that can be shared with people with lived experience of mental illness that might be after some assistance with their physical health. You'll see I've got a QR code on the page there. Now, that'll pop up a few times later in the presentation, and that is our Mind Gardens website and our resources page. So all the resources that I introduced to you today are available at that QR code. So if you're quick, you can probably get in and scan on this title page, but if you miss it, don't worry. We will come back to it. There'll be a couple of opportunities to grab in there. So Gloria's done a great job of acknowledging traditional owners and also people with lived experience. I'd really like to echo those. I myself am coming from Gubbi Gubbi country today, and I think also just building on that lived experience voice as well, that we really need to make sure that we've got that front and center of what we're doing. Psychiatry's got a terrible history of ignoring the lived experience voice, and a lot of people have been very mistreated in the past, and so we want to make sure that's front and center of what we do, especially at Mind Gardens. So some of this presentation is about change and trying to create change, and there's a good reason to want to create change, because the current status for people that live with a severe mental illness is not good around their physical health. In fact, I want to share a stat with you that hopefully many of you have seen before, but that is the life expectancy gap that people with a severe mental illness experience. So we can see here that the gap is between 12 and 16 years. And this isn't some, expansive. There are some estimates that take it up to as many as 32 years, but this is Australian data that says people, if you live with a severe mental illness, you will likely die 12 to 16 years earlier than the average Australian. So these health outcomes are even worse than what we see for Indigenous Australians. And I would very much like to see us having some targets, a little bit like we do with Indigenous health in Australia, to try and improve those healthy lifestyle outcomes. Now, it's really easy to present, the the life expectancy stats because it's a really easy one to collect. You know, we know that people die, that data's collected, you know, we know that history. What's just as important and perhaps even more important than the life expectancy gap is talking about people's quality of life. And people with a severe mental illness often don't have a great quality of life. And that is around a number of things, but physical health is also a really significant part of that. So it's all very well for us to want to close this life expectancy gap, but first and foremost, we want to improve people's quality of life. And I'd just like you to keep that in mind as we go through some of the slides today. So let's look at some of the reasons why people living with a severe mental illness have higher rates of cardiometabolic ill health and why they die prematurely. Well, the first thing off the bat is something that we know is a killer, and that is tobacco use. So what we see is in Australia, tobacco use amongst people living with a severe mental illness is 5 or 6 times higher than the general population. So it's still really high. And while rates have come down in the general population, we see in people with diagnoses such as schizophrenia, tobacco use has remained consistent over time. And that's a worry because the public health messages aren't working the same way. The taxes aren't working the same way. So I want to talk about how we tackle that as well. We see much higher rates of obesity, high blood pressure, glucose and lipid dysregulation. Diabetes occurs at 2 to 3 times higher rates versus the general population and occurs earlier in life in people living with severe mental illness. We also note that people with a severe mental illness, and some of this is driven by the illness itself, there's a low level of physical activity. So people tend to have a more sedentary lifestyle than the general population, and poorer nutritional intake. So they'll often consume a lot of takeaway, and things like their food preparation or culinary skills will be not as good as the general population. And of course, we see much higher rates of metabolic syndrome and poor oral health. So why do we have this health inequality? Well, it's really interesting. So what we see in people with severe mental illness, we know they're at much higher risk, and part of this is driven by lifestyle factors, as we've mentioned, but also part of it is driven by the medications that people need to take to treat a psychotic illness. So the antipsychotic medications, and some of them in particular, have very negative effects on metabolic health, and I'll expand on that in a little while. But with this population, we actually find that they have lower rates of cardiovascular risk monitoring. They have lower rates, and then when these problems emerge, there's undertreatment of it. This is despite this population actually having higher rates of attendance at primary care services versus the general population. We also know that this population is under-vaccinated compared to the general population as well. So there's a number of things there that are really concerning that we can start to address to provide a bit more of an equity model for this population. In terms of cardiovascular risk factors, what do we see in people living with severe severe mental illness? So when people are medication naive before they start on any treatment, when they're first diagnosed, about 6% of that population meet the criteria for metabolic syndrome. And I'm sure I don't have to go over metabolic syndrome to this audience. I'm sure you're all over it. When we start medicating people, so when people are in that first episode of psychosis, that rate of metabolic syndrome more than doubles. And so FEP is usually defined as within the first 2 years of illness. So we can see that very quickly we've got a doubling of the metabolic syndrome rate. And this is still young people. So most FEP services run from a range of 15 years to 25 years. by the time we get to someone having an established mental illness or an enduring mental illness, the rates of metabolic syndrome, you're much more likely to have it than not have it. So rates range between about 54 to 62%, depending on what medication someone is on. So not good outcomes, but what we can clearly see from this pattern is that, you know, early intervention with cardiometabolic lifestyle interventions for cardiometabolic health is going to be something that is viable here, getting in early and changing things. So, and of course, we've mentioned the importance of tobacco, and I will come back to that. So here, what is the destiny for these people? At the moment, we clearly have a majority destiny, and that is not good outcomes, not a good quality of life with physical health, but also premature mortality. But that doesn't have to be the case. And the team, Kat, along with myself and the rest of the Keeping the Body in Mind team and Mind Garden services have dedicated ourselves over a very long period of time to try and address this issue and make change. And I'm going to take you through some of those changes and what's been achieved and how we can progress further to improve these outcomes. But I'm hoping that there's a lot of general practitioners and other prescribers online today, because there is something I want to tackle first up. Now, when I present the resources, one of the main ones I want to present to you is the cardiometabolic health framework. And front and center of that is around the antipsychotic medication. Now, there's, you know, I know that, and especially in GP, then you've got to be across everything. And it makes it very difficult when you delve into a specialized area like schizophrenia. You don't have that many people that do come across or come to your office to seek help for that. And what the pharmaceutical companies came out very hard especially in the 90s and promoted some of the medications. And what I want to tell you is that there's been an evolution with those agents, and we have now much more to choose from. And the profiles in terms of the side effects of those are much better. But the important points to take away here is that, with the exception of clozapine, which we know is the gold standard for treatment-resistant schizophrenia, it often works where other medications don't work, but we have to hold it back because it's got some severe side effects, including a granulocytosis, and it has quite a strict monitoring protocol as part of that. But aside from clozapine, there is no antipsychotic that is discreetly more effective in the treatment of positive symptoms in acute schizophrenia. So don't be lulled into thinking, oh, well, this one is better than the other. In first, especially with early psychosis, the story is, sorry, that's on autopilot. The story is that the medications are all going to be equally efficacious. So what we do know, and I'll move to this next slide in a sec, but there are major differences in the side effects between the agents. And so that's what we should be basing our decision on, rather than what we think, what we're used to, because it's been around for a while, or what we actually think is more effective, because the data really clearly shows that not so much difference in the treatment of positive symptoms, but major differences between the side effects. So what you're looking at now is a frequency chart of many of the common antipsychotics that are in use. And across the top of the screen there, you can see a lot of the side effects that are associated with the antipsychotic medications. And essentially the way this works, so say we look down at clozapine here, the fourth medication, we know that we reserve that for treatment-resistant cases of schizophrenia. And we can see here that it's highly frequently to cause these metabolic side effects. And that is exactly the same with olanzapine. Unfortunately, olanzapine gets used a lot as first-line treatment in some areas. And there's clear evidence, which I'll show you in the next slide, that says that shouldn't happen. So this is very important, the cardiometabolic, and that's the focus of today's talk. But also, it's just worth noting that movement disorders are still a thing, not as bad as the older style antipsychotics like your haloperidols, where it's very frequent, but you can still see quite a few 2+ across quite a few of the medications there. Some of the more common ones are risperidone and paliperidone that do that. And also very important is the prolactin elevation there that we see is highly frequent for both risperidone and paliperidone. So there are choices, and the most of the medications that have come about since the turn of the century, since 2000, tend to be a little bit better on side effect profile. So aripiprazole has been around about 20 years now, but you can see up the top there, it's not got too much frequency of any of the side effects. Brexpiprazole is by the same company, made to be improvement. Not on there, but another medication that's been released in more recent times is cariprazine, and lorazepam is also a little bit better. So they're the kind of group that you want to be choosing medications for someone as a first-line treatment. So if anyone is out there that's still going, oh, okay, well, olanzapine's my go-to, I just wanted to highlight that there's the guidelines, what the treatment guidelines say. So this is from the College of Psychiatrists from 2016. Youth mental health management with, I'm not sure if anyone's familiar with the Origin group, that's Pat McGorry's group in Melbourne, considered world leaders in early psychosis. They've said it since 2014. And the Port guidelines from the USA, they've had it in their guidelines since 2010 that said olanzapine should not be used as a first-line treatment. That's not to say you should never use it, but we want to have all the medications possible in our arsenal to be able to treat an illness like schizophrenia, but we really want to reserve it for when others don't work, and go with something that is less likely to have severe side effects for people and impact their physical health. Okay, so I mentioned before that with the Keeping the Body in Mind team, which is based in South East Sydney Local Health District that I've worked in for a long time, and now through Mind Gardens, we've actually really tried to change the outcomes of, for physical health in people with severe mental illness. And we can see here that we've had delivered clinical interventions. There's evidence now, and we've also worked, and other people put together guidelines. So there is a lot of information out there. And for those of you that are really interested, reading journal articles, if you were just to go to one piece to get the lowdown on what is happening with physical healthcare and what should I do, this is from was a commission from the Lancet Psychiatry led by Joseph Firth, who is UK based but has spent a lot of time with us in Australia, and a number of Kat and my colleagues are on this paper as well. But essentially, it summarises what the problems are and what needs to be done to improve those outcomes. So please do check that out if you are interested in reading more about in a journal style article. Now, the challenge for us was, this is an article back from, or a commentary piece back from 2015. And there's really, and this title really sums it up nicely. There is so much evidence and data around there that, look, we know that people have terrible outcomes. This randomized control trial showed this one's done that, but so little change on the actual front. And to quote it, says clearly key priority has to be the development and evaluation of interventions that improve life expectancy. Now we've taken that challenge to heart, and that's really what we've tried to do. And over the last over 20 years, nearly 25 now, we've really worked, gone from, as simple as, okay, well, let's start looking at how often we're screening people to actually the interventions and now doing things that cross international borders, and that things have really evolved that we can support people. And it all started from this non-purpose-built community health centre. This is in Bondi Junction, where the Keeping the Body in Mind team is based. And, some of the changes that have happened before Keeping the Body in Mind came along, this was the group meeting room downstairs for consumers. We went, oh, well, it's nice to kind of have that space, but it's daggy, it's old, and it's not fit for purpose anymore. And we went, all right, can we take control of that room? And this is what was done with it. We incorporated a gym so that we could have exercise and other lifestyle interventions occurring within the community health centre. So we made it really practical and easy for people to do. Now, Jackie Curtis, together with a couple of colleagues, Hannah Newell, now Hannah Miles, but Hannah Newell at that time, was a medical student, was on placement with us. And in the photo on the top right-hand corner there is Professor Kathy Summarise, who's a professor of endocrinology. Got together and went, oh, we want to do some training and help around that. And this, what you see on screen there is positive cardiometabolic health, which we've built on. But essentially, the ambitions for this were not massive. This was prepared to help train a group of psychiatry registrars as a kind of one-off training. But it was so useful and so effective, it was able to gain momentum. And you'll see further on when I present the new resources in the package, what I mean. Just to show you some of the things that we've done. So I mentioned the Keeping the Body in Mind program. We had a pilot study where we got some money from New South Wales Health to evaluate those early interventions. We know that in the first 3 months of antipsychotic treatment, weight gain is at its highest. So on average, nearly 8 kilograms. And what we were able to show by just delivering lifestyle interventions to that group, we were able to prevent nearly all people from gaining clinically significant weight gain in that time. So only 13% of our participants gained clinically significant weight versus our control site where 3/4 did. So you can clearly see just with lifestyle interventions, you can make a really big difference with early intervention. That was all a pilot trial. We've recently published this, which has shown in depth over time that we can include this as part of routine care, that we can deliver lifestyle interventions and prevent that initial weight gain, which is just a fantastic outcome. I mentioned smoking. I'll come back to smoking a couple of times, but essentially this is what we wanted to do. Now, we've got an adolescent version of the algorithm too, which has got current smoker, individualized smoking cessation program. Now, we asked around a lot in the early days about, okay, well, what do we do around young people with psychosis and, their smoking? And essentially, this is what we got back. And this is what the College of Psychiatrists had in their clinical practice group. There's currently no evidence to guide smoking cessation efforts in people with first episode psychosis. So we were like, that's really bad. So we said, we're going to have a go at this and do it. And we were actually able to develop an intervention, which we showed was very effective in helping people to quit. I'm not going to bore you with stats, but the outcomes were very good. So I mentioned keeping the body in mind, and now I'm mentioning Mind Gardens. Mind Gardens is essentially, to a large degree, grown out of keeping the body in mind. So a lot of people that operate in Mind Gardens now, Neuroscience Network, are from that Keeping the Body in Mind team, including Kat and myself. Now, what Keeping the Body in Mind is, it brings together the 4 organisations that you can see on the screen there: Neura, Black Dog Institute, UNSW, and the local health district in Southeast Sydney, to bring together those organisations and focus on the strengths and bring them together in a pragmatic way to deliver research knowledge into real world practice. So that translational research. And some of the things that we have done is we've got in the middle there, we've got ADDI Moves, which is part of the ADDI Road service. Now, ADDI Road, for anyone that's not familiar, is a service that's been set up for refugees and provides a lot of mental health support, as well as a lot of other practical support. But we have facilitated with funding from the state government to have exercise physiology services in as part of it, and that's a great program. I also wanted to highlight the other two programs, because what's great about these two programs is that the host of tonight's webinar, CESPN, actually helps fund these programs that Mind Gardens runs. So one of them is the vaccine equity program. So that funding has allowed us to get in, and we know that you know, GPs and pharmacy services are great for you know, being able to be at the forefront and vaccinating the general population. But what we have seen is really low rates. So what this service does is it's able to see people in a setting that they're comfortable with, that they use a lot of mental health settings, and take our time explaining the importance of vaccines and dispel any rumours with a little bit of extra time that those clinicians have to actually really elevate the rates of vaccination that those people get, which is really fantastic, because it's actually a no-brainer in terms of cost savings over time, putting a bit more money into you know, encouraging vaccination amongst people. The other program that I wanted to let you know about was KBIM Primary Care. Now, for anyone that's a GP or indeed NGO, this is a service for people that are not currently consumers of South East Sydney Local Health District Mental Health Service, but do have a severe mental illness and would like lifestyle interventions. So this is something that we run also in collaboration with UNSW, and the idea is to be able to provide those KBIM-like interventions that we provide within the service outside of that to people who wouldn't otherwise be able to access it. It's totally free. It's a very easy referral. And again, on the Mind Gardens website, you can access information on referring to that service. But if you have anyone that fits that category, it's a great option to get some exercise physiology and dietetic support. I'm also pleased to know that we will also very soon have smoking cessation as part of that service. I'm going to throw over to Kat to talk through a little bit about peer support, what it is, and how it's useful in all of this.
Okay, thanks, Andrew. Hi, everyone. Yeah, just to follow on what Andrew was saying, also the KBIM primary programs, correct me if I'm wrong here, is about to have a peer support worker within that program as well. So we've got dietitians, exercise physiologists, we've got a smoking cessation person starting, and we've got a peer support worker, which is amazing. So very excited about that. So yeah, so my role at Mind Gardens has kind of evolved into, you know, a director of lived experience and consumer engagement, but that's not really, it's not where I come from. So I do come from an identified lived experience of mental illness and drug and alcohol addiction. And I was a peer support worker with South East Sydney Local Health District. I was fortunate enough to be employed as a peer support worker within the KBIM team, which is the lifestyle intervention service that's offered by CESLED. It was a role that morphed into what I would call sort of like a really health coaching role. And that was brought about on reflection after sort of 12 months of working as a peer support worker, seeing that the opportunity was actually there to adopt a coaching, more of a coaching model with obviously the traditional peer support, you know, methodologies around what peer support workers do, but to also embed a coaching model into, or physical health coaching model into that And that coaching model was based off, obviously, the advice and direction of, say, the exercise physiologists and the dietitians to help and support the consumers that we had on the program. So, yeah, the reality of the situation that a lot of people with serious mental illness is in is that they, due to things like their mental health situation at the moment, where they're at, due to the medications that Andrew's already touched, talked a little bit about the types of medications and what would be preferred first-line medications these days, they have an impact on the person's ability to actually function on a day-to-day basis, let alone to actually think too much about their own physical health and what they should be eating or doing or anything like that. So it's the state of mind that people with serious mental illness can actually stand in the way of actually doing anything about their physical health, let alone talking to their GP about it. This is where I think that the benefits of peer support can actually add some amazing value. Peer support workers come from a very non-judgmental, mutual understanding place, usually have had those sorts of challenges themselves. We, you know, as peer support workers, we work from a strength-based model of care as well. We're non-directive, we're more collaborative and open to, obviously, what are the strengths of the individual to overcome certain sorts of challenges. I remember, you know, like often sort of, you know, setting goals with clients around what they wanted to do with their physical health and talking to them a lot about, you know, rather than try and take on the elephant in the room, why don't we just look at something really simple this week? Like if they drink a lot of Coca-Cola or soft drinks, how can you cut down on that and replace it with water? What, you know, how can you do that and what can you do? So helping them to make really simple goals so that they have they're able to be successful, I guess. It's very recovery focused as well. And we're peer support workers, I know for a fact, because I've experienced this, we're in an ideal place to support the advice and recommendations of GPs. So Andrew, if we can just go to the next slide. My slide assistant, thank you so much. I had the pleasure, I guess, in some ways, of being awarded a grant with a couple of my other team members when I was working as a peer support worker, and we did what we called the Pouch Navigator project. And what that role was looking at peer outreach and wellness coaching, being a healthcare navigator. So connecting with consumers in clozapine clinic or in the depot clinic, and talking to them about the lifestyle interventions that were on offer through the KBI program, but also supporting them and helping them to navigate through, I guess, the mental health care system and encouraging them to connect back up with their GPs. So we had a target audience or a group of about 260 consumers with long-acting injectables in the community mental health service. And we were able to, during the course of that 12 months, be able to reach out to about 86% of those consumers as well, to talk to them about their physical health and what we had to offer within the community mental health service, and encouraging them to also see their primary healthcare providers. So yes, there was a peer worker particularly added to the team as a health coach and navigator for this particular project. So it was very successful. Lots of great ideas came out of it. There was some challenges as well, obviously, but lots of ways of thinking about doing things differently when we are engaging with those consumers around their physical health, etc. And also when I was thinking about, if you just want to flick to the next slide, Andrew, when I was thinking about this presentation, I actually came across this, which I thought it was pretty poignant in terms of what we're talking about tonight. So it's obviously the RACGP in 2021 made the statement around where possible, mental health professionals, including people like nurses, peer support workers, carers, etc., adult health, adult health as well, should be embedded within general practice. The reason why is it encourages strong communication between the practitioners and facilitators, basically like a no wrong door approach to mental health with patients, and obviously more effective use of practitioners' times and skills. We acknowledge the fact, Andrew and I, we do acknowledge the fact that your time is so tight at the moment. There's not a lot of time for for you to do everything in a 15-minute or even a long appointment as well. We hope to be able to advocate as an organisation for better access to primary healthcare for consumers as well down the track. But at the end of the day, we hope to as well have their if they come to see their general practitioner, we hope that we get more of a holistic approach to the care of individuals with serious mental illness. So not just their mental illness, but what's happening with their physical health as well, which probably segues me into, Andrew, the rest of this presentation around the metabolic resources, etc.
Thanks, Kat. Feel very fortunate to be able to have worked for you for a long time and have learned so much from you, and I'm sure I'll continue to do that. So, but thank you for filling us in on what is sometimes a misunderstood area of around peer support and the peer role in physical healthcare within mental illness. Now, I did just want to touch on Equally Well, because Equally Well is there. It's something that's grown out of the National Mental Health Commission, really trying to improve physical healthcare outcomes. And I know that CESPN is signed up to the consensus statement and is a supporter of Equally Well. So thank you for that, CESPN, and we continue to drive forward. Now, one of the things that Equally Well is doing is they've created a roadmap, and as part of that roadmap, you can see there's a number of things, but very high on the agenda is for the College of GPs and College of Psychiatrists to get together so that we can take these Mind Gardens resources and make them national, easily acceptable clinical resources for GPs and psychiatrists and other people that work in the space around people that experience severe mental illness. So I'm going to get now to these new resources. So to tell you a little bit about them, first of all, and very importantly, it's a co-design process. What does that mean? Kat is much better at speaking to this than me, but however, I'll give it a go. A co-design process is where throughout the entire process of developing things that the peer voice has been involved and active throughout that. So it's not designing something and go, oh yeah, do you think that's okay? But active in the production. So that's really important, and that's what we try to do with all of our Mind Gardens resources. So some of the resources have been updated. They're existing, we've updated them, we've digitalized them so that they've got links to other things, but we've also developed brand new resources that didn't exist before. There's resources for both clinician facing, and there's ones that are consumer and carer support facing. Was generously funded by the Mental Health Commission of New South Wales, and we launched at the Equally Well Symposium last year. Again, that's that QR code. So please grab a photo of that and you'll be able to link to the website easily. The website is also listed there if you want to do it more old school and just type in the www address. Okay, the slide I showed you before. So this was the original version of the framework, which, as I say, was just intended for this one-off registrar training. It, however, has moved forward and become a behemoth. It really is. This is utilised in had adaptations done in 9 countries around the world. I think 6 different languages it's in. So it really has taken off. And really, the idea is that we've been able to, there you go, I got it right, it was 9 countries. Don't just screen, intervene. And this is the resource. Okay, so I'm going to explain a little bit about how this works, because the idea is to break it down. Now, I know that for those of you that are GPs, this stuff is pretty front and center. Now, what we've tried to do, we've developed evidence guidelines along with these, so it's not like that you think people make it up. And we had a group that developed these from a really diverse range of professions, so including GPs, and we tried very much to have latest evidence and also stick with what's in the red book for GPs. So there's a consistent pattern with that. So there shouldn't really be any surprises, although there are some slight differences where we might need to be a bit more assertive with this population because we know the increased risk. A little bit like, there's sometimes different targets and more assertive interventions for, say, Indigenous Australians. So it's a little bit like that. But essentially the way it works is we've got a health factor up the top, including lifestyle, smoking, diet and activity, things related to obesity, blood pressure, glucose, blood lipids and sleep. Now, so the way it works is just to flow down. You'll notice that before we do anything, before we even notice that there's a problem, we want to provide people with lifestyle and advice, including diet, sleep, and smoking prevention or cessation. Those things are really important no matter what. We also specify here that ideally we want co-management of these physical health conditions with a general practitioner. You guys are by far have more expertise in this area than psychiatrists and nurse practitioner prescribers in mental health. We want to lean on you, we want to work with you, but we don't want to go, here's this problem, deal with it. We want to work in collaboration with you. That's the ideal. So then we've got the red zone. And the idea of the red zone is like, okay, well, if someone meets the criteria for the red zone, we want to, get some of these assertive interventions in action. Now, you'll see that a lot of those numbers are relatively conservative, and potentially some of these things you might not worry too much about it if it's a member of the general population. But we know with the really high cardiometabolic risks that these people living with a severe mental illness have, in addition to the impacts that the medications make and the lifestyle over time, we know that anyone in these red zones, this is when we really need to be ringing alarm bells, and this is where we need to bring in some assertive interventions. So the first thing, of course, is to intensify what we're doing at the start, really get that structured nutritional counselling and lifestyle interventions in place. We want to look at the medications that people are on. So just because someone was on something in hospital doesn't mean that necessarily they need to continue on at that dose or with that quantity of medications. As anyone that knows the inside of the mental health inpatient system, there's a lot of pressure on beds, a lot of pressure to push people out, so they pump medications up really high. We also know from evidence that over time, after that acute episode fades a little bit and the positive symptoms are under control, it's safe to reduce doses. Now, that can make a lot of people nervous, particularly if you don't deal with it a lot, but it's always good, and most services, correct me if I'm wrong, but I believe GPs do have access to psychiatrists to assist in decision-making around antipsychotics and other related medications, where you can get that support if you're not sure if you're doing something safely or moving something down too fast. Now, you'll see there that there's a range of things that we do. We're trying to really encourage psychiatrists to be a little bit more proactive in some of the medication prescribing, especially things like metformin, which as a GP, you know, is an incredibly safe medication to prescribe in the large majority of people. But we also want them to start thinking about, you know, having conversations with the treating general practitioner about, oh, you know, should we consider lipid lowering therapy? You know, should we be considering an antihypertensive, and trying to make those decisions in collaboration with the GPs. And down the bottom, we've got the green target zone, and where we're ideally trying to move people back to. We know that the realities of the real world, even the general population, people don't end up in that zone, but we need to have a target that we want to move towards. And so essentially it's saying, well, the intervention should keep continuing until we hit that target zone. This is a flip side document, and on the rear, what we have is the recommendations for screening. And what we really encourage is, on initiation of antipsychotics, we encourage really close monitoring of what's going on. I mentioned earlier that the biggest weight gain is in the first 3 months of treatment, and particularly the younger a person is, the more likely they are to put on significant weight. And while weight doesn't necessarily mean it's a problem by itself until later, it's the seeding of future problems that we're really concerned about. So if we can prevent, like we have done in the Keeping the Body in Mind program, that initial weight gain, then people are much likely to have better trajectories overall with their physical health. And so we encourage lifestyle review and weight check-ins on a weekly basis in that first 6 to 8 weeks. And we want to be reviewing the wider range of anthropometric and metabolic pathology screening 3 monthly for the first year people are on medications. After that, we recommend continuing those things on a 6 monthly basis, because things should be a little bit more stabilized and we're not going to get any shocks like, you know, in over a 2 month period, someone suddenly gained, you know, 8 or 9 kilograms. That doesn't tend to happen later. It tends to happen earlier on. We've also got a little bit more explanation on the right-hand side of the screen around some of the medication prescribing, you know, what you do with a review of antipsychotics and mood stabilizers. Like, you know, is there antipsychotic polypharmacy? Is there more than one antipsychotic? Is that really absolutely necessary? Because in most cases, the evidence doesn't back that, and that people in nearly all cases should just be on a singular antipsychotic medication. But that is something that often people come out of inpatient units and they're not weaned off one of them. They're just, and the problem is passed over to general practitioners without enough guidance. So please do reach out for support if you get these problems, because it really is important for physical health outcomes for people. There's more definitions there of what intensive interventions around weight gain and obesity are there, and then some specific pharmacological interventions and dosing, including down the bottom there, vitamin D, which we quite surprisingly in some ways, but often, and we don't think about this, but very commonly in schizophrenia, that can end up at very low levels. So often people need supplementation with that. Now, on the screen is another framework. This isn't Mindgun's framework, but this is the UK framework. This is the adaptation of our Mind Gardens, and this is, they've also done a 2023 update as well. Now, why I want to draw your attention to this, and so you know that we're just not making things up and like, oh yeah, we'll pull this out. So, you know, this was, the UK asked us whether they could adapt it, and we went, sure, things. They went through it with a lot of scrutiny. Now, what I can tell you about the way this resource is utilised, anyone that's familiar with, you know, UK health will know that NHS England have the NICE guidelines, okay? And the NICE guidelines, essentially, for anyone that's not aware, that is the healthcare Bible. That is what clinicians need to follow. So what they say at NHS England is that GPs and psychiatrists and other prescribers of medications for severe mental illness really should be following this. And this is a reflection of our model. So really important to, I think that international recognition, and it's not just people in Australia making this up. Now, we've also got a version of this designed for people under 18, because it's particularly important when people start off on, are young and start off on antipsychotic medications, that we really get in early and intervene really, really assertively. I'm not going to take you through this because it reflects what we've just been through, but what it does is it takes into account the percentile ratios for the different ages and medication appropriate doses and the like. So very similar, but we'll guide you to how we look after people under 18 in terms of cardiometabolic health. All right, and again, this has got a rear side which goes through and explains the same things. Now, I wanted to take you and show you one of the new resources that you developed. Around 60% of people with a severe mental illness smoke, which is absolutely shocking. And a lot of that has been tied up with things from history that's like, oh, people with mental illness don't have much, don't take smoking away from it, they enjoy it. Or, oh, you know, like it actually makes people's mental health better. Now, we know those things are myths. They are myths. There is nothing good in the overall scheme of things that you would want someone to go, it's okay to smoke. We know very clearly that if someone smokes, it is more likely than everything else put together going to be the reason that someone dies. It's that drastic. So we don't want people smoking. So we developed a tobacco treatment framework specifically for people with that experience severe mental illness. So we could guide clinicians, psychiatrists, GPs on how to do this. And I think the really important things to note here is it looks quite busy, okay, but it does make a lot more sense when you flow through it. But if someone is a dependent smoker, our ideal first-line therapy is actually varenicline for people. Now, there's some, and again, the scenario where there's misinformation that varenicline causes people with mental illness to become suicidal, makes them psychotic, things like that. There has been a number of studies now that have really clearly shown that varenicline use in people that experience severe mental illness is the negative neuropsychiatric effects are so minimal, and they are in line with the general population. And in fact, most of the things that we see very similar to placebo, and we think that perhaps some of the nicotine withdrawal itself can be problematic, but the numbers are minute. We're talking about, one particular study has 1,000 people, over 1,000 people, and we're talking about 5 or 6 people in each category that might have had a negative mental health outcome, which may have been nothing to do with the treatment at all, of course. So that is where we want to go. Varenicline isn't going to work out for everyone, whether it's choice or whether there's another contraindication. But on the other side of the screen, we talk about patches that can be used in isolation and in conjunction with varenicline, but also multi-use NRT, including the short-acting stuff. So I think this is a great resource to support people. It is busy, there's a lot going on. On the rear side again, we've just got the practical information about what to do and how to help people, including a really, down the bottom right-hand corner, just like really practical things like if there's problems with nicotine patches, some of the common problems that occur, and something that you can use as a problem solver. So please, if you find that helpful, please delve in and use it. We've also, because that is so busy, what we want to do is distill the key elements and make just a simplified tobacco treatment framework, particularly for people who are not prescribers and don't need that level of detail. So here, these are the basics. Ask, advise, help. Use varenicline. It's a safe first-line option for most people on psychotropic medication. Varenicline might improve its effectiveness. Use combination NRT and keep providing support for people who are quitting. We have also, for any allied health nursing staff and also NGO staff online, we've created clinician training videos to help break down, okay, well, you know, if we had an exercise physiologist or a dietitian or a tobacco treatment specialist, what would they actually do? And how could that translate for someone who is not one of those professionals? How could we provide that support and advice to people? So again, the same website on Mind Guns, all these training videos are available. Now I want to get in and talk about some of the consumer resources that have been developed. Now,
Andrew, we've one question that's come in
sure.
that I thought before you move on, maybe while you were covering the smoking
sure.
cessation, is that okay just to cover? So somebody has just asked that a lot of patients they see with severe mental illness are also smoke cannabis, and they just had asked how you thought would be best to kind of address that or manage that issue.
Yeah, look, I'm very well aware of that issue, and that issue is a major concern, not from the physical health standpoint, because people are still inhaling smoke and they often do smoke it alongside tobacco at the same time. But it also has, you know, some significant impacts on mental health as well. And what we, you know, it's something that is a gap, and that we want to work on to actually develop, okay, how do we assist people with quitting marijuana as well? Because a lot of the problem and the withdrawal symptoms are often associated to the withdrawal from nicotine. So I would really encourage, you know, the use of NRT. At this point, there's evidence there that will support the nicotine withdrawal element of coming, to make it one less side effect that people are experiencing. But I unfortunately haven't really got time to really delve into the thing, but it is a similar pathway. So we, you know, we keep asking about the use and advising and supporting people to quit. A lot of it's you know, that counselling and helping people come to that decisional balance. Actually, when I weigh up things, you know, the cannabis is doing more harm than good in my life, and I want to change that. So that creating that internal motivation in the individual is something that's really helpful and effective. But watch this space, because that's something that I really hope that we can develop in the not too distant future, so that we can really have a clear guidance, just like we do for the cardiometabolic and the tobacco treatment. And thanks for that question. It's a great one. So just jumping back into the resources. So these are things that if you've got limited access to, someone's got limited access to lifestyle interventions, can't afford a personal trainer, or can't get into the Keeping the Body and Mind primary service, or something else. These are module resources to help people work either individually or in conjunction with a clinician, support worker, or carer. And essentially, we've got 17 modules, and on the left, that's what they look like when we originally did them. Very, very nicely, but also very expensive to produce. So great, we could use them within Southeast Sydney mental health services, but then other people were asking us for them, and we're like, kind of like, oh, yes, we can print you some, but it's going to cost this much. And that was kind of a deterrent. So what we wanted to do was make these electronically available. And again, same website, and all these can be downloaded and in an easily printable format. And essentially the way it works is, as I said, there's 17 modules. The first module is around goal setting. So the idea is to work through this goal setting module, which helps you then identify, okay, well, what of the other 16 modules are going to be relevant to me? Because not all of them are necessarily going to be applicable to everyone. So which areas would I like to create change in my life? And it helps people set goals in the SMART goal setting style, and then to go to a module and work through that. Once they've worked through it and bedded down some change with their small stepping stones, then they might go back to the goal setting module and work through, okay, well, let's work out my next goal and work through the next module. So that's the idea. And as I say, it can be done either individually or with a support person. Oral health is also really important. Oral health outcomes for people with severe mental illness are absolutely atrocious. They are far more likely to lose all their teeth than the general population. And a lot of this is, again, it's about early intervention. So we've created 2 brochures in conjunction with NEMI National and the University of Melbourne, and one's a guide to improving your oral health. So essentially how to take care of yourself, how to brush your teeth and floss, and how often you should do those things. And the other one is about assessing dental healthcare. So how you go about seeing a dentist when it seems all that's out of reach and expensive. So what community dental clinics are out there that I can access that are not going to cost me money that I don't have. So again, QR code is appearing for you. I've been plugging this all day, but it is there. All these resources are on our website, but they're also within the New South Wales Health guideline on physical health care for people living with mental health issues. Now, obviously, this challenge is not complete. We've still got the life expectancy gap there, but we have made really significant progress. And what I'm hoping by speaking to you all today is to kind of see if we can create more change and more momentum, but mostly more collaboration, because collaboration is what's really required to fix this issue. And I hope that we can do that. My email and Kat's email are both on the screen along with our website. Please, if you have any questions or queries post today, please feel free to reach out to us, and we will do the best we can to answer your questions or connect you to the right people that might be able to help. Now, that is the end of the formal presentation. I am more than happy to expand on anything. I'm not sure whether there, at this stage, are any more questions or comments that I can or Kat can assist with.
So far we haven't, but I might just keep it open for a little moment to see if we do. We have had one person just thank you for the great topic and presentation, and yeah, I would like to echo that as well. It was really interesting, and I think finishing on that kind of topic of collaboration was yeah, was really good. And I know, Catherine, you touched on the term, you used the term holistic, and I thought it was a great term to use. I think kind of trying to come at this kind of from all angles, like kind of seeing what medication is kind of most appropriate, and then the lifestyle. And then I really think that kind of support and peer support in particular is really important. And yeah, I just wanted to mention that CESPN has quite a few psychosocial programs. So in addition to the Keeping Body in Mind program, there is other support programs, and we've actually another 6 new psychosocial programs that should be available in the next kind of couple of months. So yeah, I do think it's one of those things that it's not a simple one one fix. So I think yeah, it is trying to kind of tackle it from all angles. So no, thank you again. It was really really comprehensive. So I think it was really good. We have had one question come in. So have you found people becoming more hopeful as they kind of progress through the programs? So I'm not sure if that's referring to the resources and going through those, or the Keeping Body in Mind program, but I don't know if you are able to respond from either.
Yeah. Did you want to talk about, some of the impacts of the KBM adult population for people with enduring illness that have had illnesses many years, and some of the people attending that?
Yeah. So thanks, Sandra. Yeah, it's a really good question, and the answer to it is yes. Yes, we do find that that individuals who attend our Keeping the Body in Mind programs through community mental health or through the KBIM program primary, they become more engaged and they become more hopeful about their own physical health. For example, if I reflect back on my time when I first started at KBIM, we did struggle at times to get a lot of people to engage and stay with the program. But when we changed the model and we had the role of the peer support worker health coach in there, we offered coaching once a week for everybody who attended the program. Plus they had their group sessions on physical activity and nutrition. And what we did as a team, we actually created an environment of connection. We supported successes and encourage those successes, and we focused on the strengths, etc. So we had some, we had a lot of individuals. I think on average, I think our group sessions were something like 16 people each week. And we had some wonderful success stories of connection. When we did our surveys, one of the things that came out was, I really felt part of something. I felt part of a team. I love the fact that my successes were celebrated by everyone, including the people who were my peers within my groups, etc. So it's not just about the physical health. It's not just about diet, nutrition, smoking cessation. It's also creating support around a person to encourage and support their success. So yeah, it's been a wonderful journey.
Yeah, thanks for that, Kat. And just to add on to that, because I think also Barbara, you were asking about both the resources being helpful as well, and definitely what we can see is that we've got the luxury to a degree in Southeast Sydney local health district with the resources that we have to be able to provide this really extensive service that comparatively has a lot more thrown at it than in some other places. So the idea with the resources, we've had lots of feedback from places outside of Southeast Sydney local health district where they've been able to utilise these resources, and hope is such a good word to use, that hopeful in the program, because we really do see changes in people's hope. It's not always the case that people's weight changes when they participate in these programs, but any GP with their side will tell you that's the case with the majority of the general population, that people have incredible trouble losing and maintaining lost weight. But what we do know is that people reduce their cardiometabolic risks. They can do things like drop their blood pressure, their cholesterol improves, they're more physically active, they're eating better. All of these things are lowering cardiometabolic risk. But the most important thing that we see, because it wasn't really what we were targeting initially, but people coming through these groups, it is hope. People feel better and their quality of life is better and they're more engaged. And, often when we ask people about, what's the best thing about group, and some people have had amazing changes. Like there's been, like it's not all that common, but some people have lost, 15, 20 kilos in these programs. And you ask them, what's the best thing about coming to a group? They're like, I've got friends now. So it's just that hope that it creates. So really positive. And, the idea was with the resources is to grow this out so other people can access it. We can be bigger than just Southeast Sydney in terms of the amount of people that can reach and improve their life. Yeah.
Yeah, and we have a couple of more of other questions. So the next question was, on the Oz CV risk calculators, there's no area where mental health is added are you aware, or do you know if this is changing, or?
It's a very sad reflection on what happens in a lot of general areas and descriptions. So I'm going to come back to the CV risk, but just to highlight this, up until really recently, and we're not fully there yet, but all the smoking cessation plans that were put around, despite 60% of severe mental illness consumers being smokers, there was no section dedicated to, okay, how do we address that in this population? There's this population of special needs, with things like migrant populations, Indigenous populations, pregnant women, all really important groups, don't get me wrong, but there's a significant missing piece, and that we find that across the board. And it's a group that is not very good at advocating for itself, people with severe mental illness, and that's why things like Equally Well and what we're doing in Mind Gardens is so important to advocate and get changes, so that, hey, we know this population is at greater risk, so it should appear on the Australian CV risk calculators that there should be different cutoffs for this population. And so that's a work in progress, and something that we'll keep pushing for and advocating for, and Equally Well will do that too.
Mm-hmm. And we have another question, and I apologize in advance if I don't pronounce the medications correctly, but the question is, I have a patient who is on Abilify and olanzapine. She has obesity and hypertension and tachycardia. The psychiatrist put her on propranolol and discharged her to the GP. And just touching on that, you mentioned not having somebody on multiple antipsychotics, and just, I guess, your kind of your assessment.
What I would say to you was, there's 3 medications there. The propranolol, is that I'm assuming that's probably for anxiety, even though that doesn't get used for that very often anymore. But anyway, back to the main issue, the 2 antipsychotics. People often throw an extra medication at something when things don't appear to be working in the acute phase. What I would say is the ideal in that situation, each thing's individual, so it's very tough giving individual advice when I don't have everything in front of me. But generally speaking, aripiprazole is a newer medication with a better range of side effects. So it might be that things have been tried with this person, and that might be the only combination that works. But chances are that's probably not the case. It's probably that one medication will work equally well as the other. And what I would generally advocate in this sort of situation, without knowing the full details, is that aripiprazole as a sole medication would probably do best. But little caveat, olanzapine is an absolute bugger of a drug to come off. People get withdrawal syndrome, anticholinergic withdrawal, and that's why one of the reasons why people think olanzapine works and other medications don't, because they come off olanzapine, go into another medication, they get unwell. But it's actually the withdrawal from the olanzapine that is the problem, not the new medication not working. So for anyone that is thinking about switching someone off olanzapine, it needs to be done really slowly, and particularly at the end. So doses, if someone's on a high dose, like say 20 milligrams or something, dropping from 20 to 15 is not a massive deal. Dropping from 5 to 2.5 to 1.25, they're massive deals. So the attachment to the receptor sites really hangs on to that last thing. So really slowly over weeks and months, just very gradually reduce down any time that you're reducing or looking to remove olanzapine. Really, really crucial, because you do risk that. That's not to say that you shouldn't do it. You should definitely tackle that if you feel that people have better outcomes with their physical health without it. Just do it slowly, otherwise that risk is there. It's definitely over a number of months rather than just a couple of weeks.
Okay, thank you. I just actually had one question myself as well. I guess I was just wondering what your kind of opinion is on weighing up the the symptoms, or sorry, the side effects of certain medications versus the symptoms of severe mental illness. And yeah, at what point do you think the symptoms kind of are probably more important to manage and treat and deal with the kind of physical symptoms?
Yeah, I mean, Kat might want to add into what I'm saying here with some perspectives from a lived experience perspective. But generally, for most people that experience psychotic illness like schizophrenia, antipsychotics are essential medication. It's not an absolute rule, but for the majority. In fact, one of the really large Scandinavian studies done in Finland shows that people that cease their medication upon leaving hospital are twice as likely to die prematurely as people who continue on their medication. And some of that through increased suicide and accidental risk of death, but it's also from things like increased cardiovascular risk because people are not in a position to take care of themselves and make good lifestyle choices. So we need to be really mindful of that and balance that. But as I say, the general rule is that for most people, these medications improve people's lives despite the severe range of side effects. The idea is that we want people on as little medication as possible that keeps them well without doing too many other things that we don't want to happen to people, would be my nutshell answer to that. Kat, did you have anything you want to add into that?
No, not really. I think you covered that really well. Thank you.
Yeah, thank you. That was good. We haven't had any more questions come in. So we might leave it there. I can give it maybe another minute or so, but I'm not sure if any more questions are going to come in. But yeah, I would just like to thank you both again. It was really interesting topic and very comprehensive and a very holistic kind of approach to it all. So I hope all of tonight's attendees found it useful as well. And if you didn't get a chance to catch the QR code or the link, that will be in the slides that we'll share following the event as well. So you'll have a further opportunity then to access the Mind Gardens website as well.
Thanks for that. Did I forget to mention the QR code?
Just in case anybody didn't catch it. But yeah, thank you. And yeah, thank you for all the work that you're doing. There's a lot of great resources on the website. So hopefully people do actually take the opportunity to have a look and make use of those great resources. But yeah, I will let everybody have 8 minutes back in their evening, and just a reminder as well that the evaluation survey will pop up on your screen. So I think Catherine and Andrew would love your feedback, and we would also love to know of future topics you're interested in hearing about. So if you can fill in the evaluation survey, that would be greatly appreciated. So good night, everybody, and thanks for attending, and thanks again for the great presentation.